Now that you've heard Jeffrey's story, we can talk about how and why, despite these unrelenting symptoms, Jeffrey is still waiting for treatment that will work. You see, when Jeffrey goes to one of his many appointments, instead of the practitioner saying, "I've seen this before, this is fear of harm," doctors and therapists aren't yet aware of this diagnosis. And when they turn to the DSM, they're coming to the wrong conclusions, which leads us to our first topic. Why are our children getting diagnosed with so many different, incorrect diagnoses? In order to answer this question, we have to look to the DSM, or the Diagnostic and Statistical Manual of Mental Disorders, which is used by mental health professionals to help classify observable symptoms into different diagnoses. It was created to simplify the process of diagnosing and to help mental health professionals communicate effectively with one another by creating a common language for diagnoses. We'll talk about this in more detail in the second module, but for now, we just need to know that in order to do this, the authors focused on observable behaviors and gathered symptoms into combinations that were then given a name. This is why, in the DSM, diagnoses list symptoms as criteria, and to qualify, the patient needs to show a majority of those symptoms. But many symptoms appear in multiple diagnoses. Think of it like putting together bouquets of flowers. You choose from carnations, roses, baby's breath, lilies, and daisies. And depending upon the combinations, the final bouquets all look different. As a result of this system, the boundaries between diagnoses are somewhat porous, meaning that certain symptoms can be found present in many, many different diagnoses, which can make differentiating one from another difficult. For example, the diagnostic criteria for disruptive mood dysregulation disorder includes severe recurrent temper outbursts manifested verbally and or behaviorally that are grossly out of proportion in intensity or duration to the situation or provocation. And temper outbursts occur on average 3 or more times a week. Now, the diagnostic criteria for intermittent explosive disorder includes verbal aggression or physical aggression towards property, animals, or other individuals occurring twice weekly on average for a period of 3 months. The physical aggression does not result in damage or destruction of property and does not result in physical injury to animals or other individuals. And the magnitude of aggressiveness expressed during the recurrent outbursts is grossly out of proportion to the provocation or any psychosocial stressors. Yes, these behaviors are described with slightly different wording, and one could argue that the language difference represents meaningful differences. But when symptoms are reported by patients and their families and are observed by practitioners, how do we definitively differentiate verbal rages occurring on average 3 times a week from verbal aggression occurring twice a week on average, when this week they happened twice and last week they happened 3 times? The truth is that we can't. Without a known biological cause of an illness, the diagnostic process becomes essentially guesswork. And while practitioners are making their best, most educated, well-considered guesses that are often correct, they're still guesses. This is why our kids with fear of harm are walking out of doctors' offices with diagnoses of oppositional defiant disorder, intermittent explosive disorder, conduct disorder, ADHD, obsessive compulsive disorder, disruptive mood dysregulation disorder, post-traumatic stress disorder, and more. These kids are showing symptoms from each disorder, like arguing with authority figures, having temper tantrums, initiating physical fights, not following through on instructions, experiencing recurrent persistent thoughts that are intrusive and unwanted, recurring temper outbursts, and recurrent distressing dreams. You see, the blurring crossover between diagnostic categories without biological underpinnings is the best we can do in the DSM model. But we can do better, and we are doing better. With fear of harm, we have the first ever biological marker, an indicator of a physical and biological event that is independent of the psychiatric symptoms. And this sets fear of harm apart from all other psychiatric diagnoses. We'll talk in more detail about biomarkers in our second series, Understanding Biological Causes, but for now, let's move on to our next video in this series, where we take a deeper look at the symptoms of fear of harm.